We're going to just now go back and ask a few questions to ourselves about stigma and bias in sickle cell disease. You've heard now, you've been around the world, right? So you've now talked about Minneapolis and Syracuse and what happened in redlining, and you've now looked at the Virginia problem, and you've looked at what Virginia is doing and other states are doing. Let's just bring it back now to sickle cell disease. So we started out at a very global level, talking about applying these sciences of political science and social science and behavioral science and biological sciences to sickle cell disease. Now we're going to come back and say we know a little bit about those. We've heard a little bit about the data. What's going on with sickle cell disease? Now, for those in the sickle cell audience, get your tissues out. This is going to be a gripping little presentation that we're going to make. And we're going to talk about stigma and bias in sickle cell disease itself. And we're going to get real personal. So I think there's a question up there, right? Is there a question up there now? Yeah, it looks like it might be for tomorrow. Is that for tomorrow, or is that for today? Yeah, I think that one's for tomorrow. Okay. So let me go on. Let me move on. No, okay, it is for today. So here's the question. In my opinion, race relations in the United States are 1, terrible but improving, 2, terrible and getting worse, 3, okay and improving, 4, okay but getting worse. There is no right answer. Well, it sounds like we may have convinced you that things are getting worse. We certainly have given you enough data to suggest that. But I suspect that you're just watching television and experiencing in your own personal lives how things feel. And I would agree that, in my opinion, if I were answering this question, I'd say terrible and getting worse. Okay, next question. In my opinion, people are 1, pretty much the same everywhere, 2, very different, probably should say very different, and will never see eye to eye. 3, people are very different, and they need to learn how to understand each other. This is opinion. Okay, so an overwhelming majority are saying, yeah, people are very different from one another, and we've got to learn how to understand each other. So in that spirit, let me just move ahead and tell you about some realness. And Daniel, you think this is going to work now? Do I do one more? All right.
Social history, ex-smoker. Denies
Do I do it again?
Intravenous drug abuse. Doubt that very much.
You should be hearing audio.
Patient is non-compliant and has no regular primary medical doctor. Comes to hospital frequently for morphine sulfate for pain. States only morphine sulfate helps.
So when you see these kind of comments, what do you think about that?
Prejudice.
That's a strong statement.
It's prejudice. Let's analyze that term, non-compliant. That's a pejorative term. We don't use that term anymore. It implies that you made a rule and that they broke the rule. Another pejorative statement insists that only morphine sulfate helps. Well, most patients have been experienced enough with their pain to know what works for them and maybe even what dose works for them. It doesn't help that he's a young black man. It doesn't help that he doesn't have a doctor who knows him and can vouch for him. And it probably is true that he is defiant and oppositional when he comes to the hospital because he's expected that he's going to be treated badly. And so it's just, nobody's trusting anybody. That's what I read into all of this. If I'm wrong, I'm sorry, but that's...
Okay. So what you just heard was my voice, very unmistakable, but I was being interviewed. I was being interviewed for a public health radio broadcast called The Realness. We were discussing the rapper Prodigy of Mobb Deep, who had sickle cell disease and passed away from sickle cell disease. And we were looking at his medical records. Mobb Deep was brought before a judge in Nassau County for criminal charges, and while incarcerated, started having sickle cell pain and sickle cell crises. The lawyer for Mobb Deep, the prosecutor, I should say, against Mobb Deep, got very interested in his illness, because this is a prosecutor supposed to be sure that this person gets convicted and punished for some crime, having pity for the person who's incarcerated because he clearly seemed to be sick. He was unable to make his court dates. He was unable to participate in the trial properly because he was ill. He ended up in the hospital a lot. The judge in the case gave no empathy to Prodigy for his illness, sickle cell disease, and thought it was all a front. So what the public health station did, the public broadcasting station did, was look at the medical records themselves and ask the question, was this legit? Was Prodigy faking it, or was he really sick? And what they discovered were the records that I read from, in which a physician treating him made pejorative statements accusing him of faking it and downgrading him for asking for a specific medication. Does that sound familiar? That 19-year-old that I presented to you at the beginning? While that wasn't Prodigy, that was a completely different fictitious patient, it might as well have been Prodigy, saying, I am sick, I'm angry. Both were angry. Prodigy was angry. He made many videos expressing his anger. But he was ill, and he was asking for what he thought was the best care, and asking the judicial system to give him the same treatment it would give, in his mind, a white person with a painful illness. And he felt he was robbed of justice, and this whole program was trying to make that point. And when I read the records, I started siding with the defense that he was not treated fairly. I would say that was probably not just implicit bias, but probably some explicit bias going on in the way he was treated. But certainly in the medical record, the person writing the things that they wrote about him was probably guilty of prejudging him as faking it. So, I think you have endorsed my first point. I believe America is polarized. I think you would agree that we have some strong bases that race, class, implicit bias, maybe explicit bias, and stigma are at the root of this polarization. And I think you would agree that both from the example of Prodigy, but from some other data I'm going to show you, health disparities exist in sickle cell disease, implicit bias and stigma, which are in all of healthcare and all of health, pervade sickle cell disease. And we don't like talking about it. We do not like facing it. I do not like watching the news and hearing that my country is divided and that we can't talk to one another about critical issues of culture, race, and class that divide our country and that we need health healing from as a country. And I am on a campaign. You could say I'm thrust into this campaign because here I am dealing in a predominantly white healthcare system with patients who are predominantly black as an African American physician. And so I'm kind of having to be a bridge. I'm having to move between cultures, if you will. And we all need to do that. We all need to decide to move between cultures, to take our own culture into account when going on a cultural journey of somebody not like us, and understand what it means to accept their culture, to adapt even to understanding their culture, and then vice versa. I don't think that this is just something that doctors have to do, but you know what? Patients have no choice. They have to adapt to the culture of medicine and to the majority culture, but we have a choice as physicians whether we will adapt and adopt. So, if you haven't figured it out, the political parties are going their own separate ways. In the bottom left there, we are in a broken rowboat. It is sinking, and the two parties are rowing as fast as they can away from one another. And the rest of the symbols on the screen are self-explanatory. The racism and the outrage surrounding the George Floyd murder and COVID and its effects on race and on politics and vice versa. And on the right-hand side, just some polls showing the political parties over 2 decades drifting apart. There is no civil dialogue going on. And you have heard many times during this afternoon how lives are at stake because of health inequities. And you have now seen that we have more and more people of color coming into the country. We will be a majority minority country by the year 2050. Whites will be at a minority, and African Americans, Hispanics, and natives will outnumber whites. That is coming up in 20 or so years. You are familiar with the racially charged slogans running around, including, I would say, Black Lives Matter. I think that's racially charged. I think it's divisive. I understand the meaning of Black Lives Matter. They do. But then you've got the retort, well, all lives matter, ALM. And then you've got the divisive term, Make America Great. How can we talk to one another in a way that invites dialogue and not rebellion and war? The scriptures say that a house divided against itself cannot stand, but not only the scriptures, St. Augustine, Thomas Hobbes, Thomas Paine, Abigail Adams, Felix Walker, even our President Abraham Lincoln said the same thing. And you've now seen that we have race. We can't say that skin color is race. Race is a social construct. You heard that very clearly. We invented it. In fact, biologically, there is more genetic diversity within the racial category of African American than there is between African Americans and Caucasians in the United States. Now, what about sickle cell trait? We have not said this before, but let's talk about sickle cell trait. Sickle cell trait is a biological phenomenon. It is an evolutionary adaptation to malaria exposure, and in the places where it spontaneously arose, it thrived because people with sickle cell trait had resistance to falciparum malaria. So where there were higher rates of falciparum malaria that happened to be in the sub-Saharan region of Africa, we see higher survival of people with sickle cell trait. And people who live in other parts of the world, such as the Mediterranean and the Middle East, would also survive more were they to have malaria indigenous in their regions. We've now said very loudly that a disparity is not simply a difference in health outcomes by race or ethnicity, but a disproportionate difference attributable to variables other than access to care. And what are some of those disparities in sickle cell disease? We've already talked about some of them. So here's one, the life expectancy, extremely disparate, 30 years shorter than that of people without sickle cell disease. What about hospitalizations? Very high rates of return to the hospital within 30 days of discharge in sickle cell disease. This gets the attention of hospital administrators. It is viewed as the patient's fault. And when you create a sickle cell program, if you haven't figured it out yet, you can use that to your advantage. You can go to your hospital administrators and say, I want to help you get your readmission rates down for sickle cell disease and people coming to the hospital and returning to the hospital. Can you give me a program to do that? And a lot of times you will get positions in order to try to decrease some of those costs. But not only hospital admissions, the rate of stroke is 3 times higher. You heard that from Dr. Sisler. The rate of stroke is 3 times higher in adults even with sickle cell disease than in African Americans of similar age without sickle cell disease. And I think she said it was something like 20 times higher in children. And then what about this disparities in terms of resources? The majority of patients with sickle cell disease happen to be Medicaid beneficiaries, and less than 70% of doctors in the United States accept new Medicaid patients. Sickle cell patients wait longer to see the doctor and to get pain medication. We already talked about pain treatment disparities. Dr. Royster mentioned that. The number of physicians to treat adults, especially with sickle cell disease, is extremely limited when compared to the number who treat cystic fibrosis, cancer, hemophilia, or any other similar disease. There's 3 times more federal funding per person for cystic fibrosis than there is for sickle cell disease. But cystic fibrosis affects 1/3 the number of people that sickle cell disease affects. There's 75 times more funding from foundations for cystic fibrosis versus sickle cell disease. Yet sickle cell disease affects 3 times as many people in the United States as does cystic fibrosis. Okay, I think this term may have been defined or it may not have been. Implicit bias, what is that? It is also called implicit social cognition. It is an attitude or a stereotype that affects our understanding, our actions, and our decisions unconsciously. So we don't recognize that we are discriminating. We don't recognize that we are behaving disparately. It's just built into our emotional DNA, and it's all becomes unconscious, and just it's the way we do business. An example of implicit bias was probably most famously demonstrated in this article. These are 4 fictitious patients presented to cardiologists at a national convention. The cardiologist only saw 1 case per doctor. And the clinical presentation was printed under the picture exactly the same, regardless of which picture the physician was shown. And the simple question was, would you catheterize this patient? The patient had chest pain. They described the chest pain, probably somewhat typical of what you might describe if somebody had angina, but maybe it was a little bit fuzzy as to whether they had angina or not. And the idea was to see, would the picture influence how often the patients got catheterized? You can see a slightly little red box around the picture in the bottom right. The white male was most likely to get catheterized. Would you like to guess who was the next most likely to get catheterized? If you guessed the white female, you would be correct. How about who's next most likely to get catheterized? If you guessed top left, the black female, you would be right, leaving the brother in the top right as the least likely to get catheterized, given an identical presentation. So this was a demonstration of racism and sexism implicitly in the behavior or intended behavior of cardiologists, and it made the New England Journal and made a lot of fuss. Back to our difficult patient that we presented at the top of the afternoon. So now your word cloud is sort of getting reinforced and it's coming clear that these patients are not just difficult, but they're actually vulnerable. They're actually stigmatized. They're actually underserved. And yes, they could be medically challenging. And yes, they could be attitudinally challenging. And they could be very obnoxious, like Prodigy likely was, and angry, like Prodigy likely was. But they're stigmatized and sometimes financially destitute. And they've had years of treatment leading to their feeling the way they feel. And this was so important that it got press in the Journal of the American Medical Association in the bottom left there, treatment of sickle cell disease pain, fostering trust and justice. So the doctors think the patients are addicts. The patients think the doctors don't care, don't prescribe enough medications, and are racist. And you can understand how these stereotypes could not promote, but distract from good dialogue between doctors and patients in a high-intensity situation such as an emergency department. So what do we do as doctors, nurses, social workers, providers? How are we going to approach this patient? And I'd like to introduce this term, adverse childhood experiences. This is sort of a new buzzword now. The idea is bad things happen to you during your childhood. You carry them with you during your adulthood. They scar you, they shape your psyche, they make you who you are as an adult. An example would be the adult child of an alcoholic or the adult child of an abusive parent. How about being the adult who had sickle cell disease as a child and had what you perceived as an abusive environment in the healthcare field? You think you might have difficulties, and you think you might come by your chip on your shoulder honestly. I'd say yes. So you would say that really didn't sort of happen by choice. Maybe it was poor adaptation, but they can't undo the experiences that they've had. And our job now is to not ask them to fix themselves. We will talk later about Black people don't go to therapy. I can't wait for you to see that video. It's very funny, but very true. So we have to figure out how to support where those patients are, meet them where they are. That's what we do for all patients, meet them where they are. What is the social stigma? It's the disapproval of, discrimination against a person based on perceivable social characteristics that serve to distinguish them from other members of society, such as culture, race, gender, intelligence, and health, etc. And are patients stigmatized? Here's some data. All of these residents had some experience taking care of sickle cell disease, and you can see that they felt less comfortable taking care of patients with sickle cell disease than would be ideal. They felt like it was frustrating to care for them, that it was not easy to empathize with them. Maybe they over-report their pain. Does not make the resident glad that they went into medicine. And you can also see here that only 51% of this sample was white. I'll let you fill in the blanks there. So we've got structural racism, we've got interpersonal racism, such that patients feel they have to adapt. What do they do to adapt? These are anecdotes. Before I go to the emergency department, I am not saying this is correct to do. Before I go to the emergency department, I put my makeup on, I put my lipstick on, and I make sure I look presentable so I'll get pain medicine the way that I need. Or the doctor calls me and says, I got a sickler down here, Dr. Smith. I don't know what to do with them. They have now objectified the person. They have become their disease. Forget who they are as a person. They're a sickler, and I want them to stop sickling. We don't use that word. We try not to use that word. So if you have to walk away from anything that I said today with a single thing you can start practicing, stop saying sickler. I don't think I have time to go over this one. Dr. Royster can probably give this slide much better than myself. But health equity is our goal here. Not merely equality, where everybody is treated similarly, but health equity, where outcomes are similar. And justice would be where people are actually caught up from being behind. That's what we hope will happen with sickle cell disease, and we are a long way from achieving it in sickle cell disease. I think I gave this slide already, so I'll skip it. And I'm gonna just briefly touch on this slide. Here is the sort of 15 commandments to reduce racism in patients with sickle cell disease. And you can sort of pick from the things that you think you'd like to work on. But they are trying to address all of the levels at which racism has an impact on patients with sickle cell disease. So at the community level, the structural level, the institutional level, at the personal level, trying to introduce interventions that might stop the current deluge of oppression that patients with sickle cell disease face as a result of having their disease and being in a racially charged and racially unequal environment. We don't have reports from sickle cell disease quality that are abundant. The American Society for Hematology did put a report card out, and you can imagine we got failing grades for how we're doing. I'm not going to bother to show you that. But here is a set of charts and reports that can tell you by state, by race, by ethnicity, how we're doing in general with regard to healthcare quality and healthcare disparities and health disparities. The chart format shows your city, your state. You can put up, besides some of the slides that Dr. Steve Wolf showed you today, you can put up your state and see how you're doing. Maybe we will get to the place. I have been hoping that we will get to the place where we'll have these kinds of reports about sickle cell disease care specifically, paired besides outcomes. All right, so let's get up close and personal. What can I do about my own attitudes? Well, first, identify them. Commit to making a journey towards improving your own cultural competence, cultural humility, and sensitivity. Here is one of many tests or surveys that you could use to help identify where you are. This one's called the intercultural. I can't remember what the IDI stands for now. The inventory is the last word. And what it's doing both is thinking about yourself and how you identify, but also about your thoughts about other cultures. So the self part is the identity, that part of your concept which derives from your knowledge of membership in a social group or groups, combined with the value and emotional significance attached to that membership. Many may think about the example that was given when Barack Obama became president. People sort of said, he's not culturally black enough for my taste. And I thought to myself, you just can't get satisfied. And I think by that they meant they didn't feel he identified enough with their own cultural experiences, backgrounds, values, etc., because he came from Kansas and there were white people in his family and so forth, and then other people said he wasn't even born in the United States. That's what the identity part of this is judging. Now this one is judging your beliefs and attitudes towards other cultures. You could be on one of two poles. Denial. Denial is saying people are basically the same. I don't know what y'all talking about. We don't have no problem. Polarization is people are very different and I don't like it. Why can't everybody be like me? Minimization is, yeah, I don't really want to talk about that. We don't talk about race at the dinner table. Let's chill. Let's all get along. Acceptance. Okay, I've begun to think about how people are different, and I can start to accept that people are just not necessarily going to see things my way. I don't necessarily like it, but okay. Adaptation, 2.4% of the population. I actually can identify with the way somebody who thinks very differently than me, looks very differently than me, the way that they think. And I can take their side in talking to them, caring for them. And this bell-shaped curve is no accident. This is the way the population in many scores of surveys given to groups in the United States, this is the way they play out. Your trailing orientation is the one that you most likely revert to in stressful situations. So if you're in acceptance and you get stressed, you might reverse and go to minimization in your reactions. And your leading orientation, of course, is the one ahead of that. Here is VCU. On the left-hand side is medical students. You see the bell-shaped curve. On the right-hand side is faculty. You can see the bell-shaped curve. We don't like that. When we showed this to the faculty in particular, they were pissed off. They didn't want to be told, I ain't no racist. They don't want to be told that they might actually have a place to go on the journey. I was one of those faculty. I didn't like my score. Your developmental orientation is where you actually are according to this inventory. Your perceived orientation is where you think you are, and the gap between the two is the orientation gap. The wider the gap, the more work you may need to do. The orientation gap for VCU faculty was 22. So we're risk averse, we live in cocoons, we like to talk to one another, we don't have friends of different backgrounds, and especially that's true in the medical culture, and we think we're perfect. So we've got to get out of that attitude. We got to take risks. We've got to start having difficult conversations about current national events, or just you can get less risky than it and talk about sickle cell disease and caring of patients with sickle cell disease with somebody that maybe thinks differently than you. Maybe you go to your CBO if you're a doctor, or if you're the CBO, maybe you can talk up one of the physicians and say, hey, I'd like to just talk to you for a minute. You're not there to correct each other. You're there to enter each other's cultural space. You're there to dialogue and not to debate. You're there to offer your perspective and your experience and to listen. So I hope you understand that this is difficult to do, but I dare you. I dare you to try it. I think this is where we are in really moving the needle on improving care, interpersonal care in patients with sickle cell disease. And with that, I'll invite Dr. Royster back up. I may have some more slides, but I think I've made my points. So you can put your questions in the chat, and I'll lead out by asking Dr. Royster the obvious question. Can black people be racist?
Well, it's a good question because I know a lot of people ask it, and I would answer it by going back to the definition of racism that I gave from Dr. Kamara Jones, that racism is a system, and in the United States, a system based on the belief in the superiority of whiteness and white people, and in relation to people of color, and then the distribution of society's resources, opportunities, and burdens according to that belief. And so I would say that if a black person acts in a way that reinforces that system, then they could be considered to be racist. And so while I think that's different, though, than a lot of people think when they say, oh, you know, someone's being racist, reverse racist often is the term, because they're giving people of color an opportunity that they don't think they should have. And I would actually argue that that person is actually probably being anti-racist, because they are recognizing that the playing field is not level, and they're creating an opportunity where people of color have an opportunity where they otherwise would not, as a way to balance the unbalanced playing field. And so in that case, they're oftentimes very conscious of how racism plays out and are taking efforts to be intentional about ensuring that their workplace is diverse, or there's, you know, whatever it is they're doing adds diversity and opportunity to people that normally don't have it.
What are some other questions that you get asked when you go out and give talks, especially when the audience might not agree with you on every slide?
That's a good one. I think a lot of times we'll do workshops with groups, and one of the things that comes up is the idea. We also talk about privilege and how that plays out. That, you know, we can talk about white privilege, where white people live in a society that is really set to support and encourage them, and they don't recognize that. And I can relate to it as, you know, as a man, there's male privilege that, you know, there's society set up in ways that benefit me, that disadvantage women, that, you know, I've learned a lot from, and so I'm kind of going off on a tangent, but that's one of the things that comes up around privilege. And I think people really want to push back on, you know, I've had, particularly say, if we talk about white privilege, white people might say that, oh, I've had challenges in my life also, so I don't see that I have privilege. But when we're talking about white privilege, we're talking about it relative to people of color. And so all of us have various identities. You know, I'm both black and I'm a man. As a man, I have privilege, and as a black person, you know, society discriminates against people of color. And so there can be, both can exist at the same time. A white person can have privilege as a white person that gets them into doors for jobs, et cetera, that gives them the benefit of the doubt if the police stop them. And they may have grown up poor and have challenges with that too. And so I think it's really getting beyond the defensiveness of privilege as being something bad. It's just a reality of the society that we live in based on who's valued more so than others. And if we think about privilege as actually an opportunity, that we can use that privilege to speak out and be an ally to people who don't have the privilege, then we can actually turn it into a positive.
I get this kind of reaction. I go to a predominantly white church. It's a Protestant church, evangelical church. I'm all those things. But I'm also a social progressive black person working in sickle cell disease. And I get this. They're bashing me. Why are they bashing me? Wally, why are they bashing me? Can you make them stop bashing me? You don't bash me. Why are all these people bashing me? What do I say to them?
And this is religious white people?
This is a country club, religious white people who feel safe enough to say to me, a black person, they, not me, are bashing me. And you can see I'm going on this journey that I've just been talking about, about difficult stuff. Can you imagine how that conversation might have opened up? It might have opened up with, hey, what do you think about what's going on in the Ukraine? Or hey, what do you think about happened on January 6, 2021? Or hey, and we're sitting there having dinner together. And that's when the conversation will come up. They feel close enough to take a risk.
I mean, why are they and they being people of color, or
why are people of color bashing me?
Well, I mean, I think that person, I think really ideally they should be open to that self-exploration. I mean, I think that's what's necessary, and you kind of talked about it, earlier in your slides, that we have to be open to those courageous conversations, but we also have to be open to looking internally and seeing, where we have privilege, where we have blind spots, where we have maybe even unintentionally disadvantaged people, and be open to acknowledging that. I mean, again, when we do our trainings and workshops with folks, we talk about we've all grown up in a society that from the beginning has taught us who's more valuable than others, and how to treat people based on their social identity or their social class. And so it'd be unlikely that any of us would grow up and not internalize that. And so someone who has privilege maybe their whole life, they've probably internalized a lot of that and aren't even aware of it. And so it's incumbent upon people in that situation to be vulnerable and to acknowledge that, I don't know everything. I may say racist things. I may say sexist things. And that's part of the reality of where I've grown up. And now that I'm aware of it, I can change. I can grow and develop.
Sounds like AA for me. The 12-step program. First, you got to acknowledge you got a problem.
Exactly.
Yeah. Well, I don't think that there are any questions coming from the audience. Clearly, there could be small group gatherings coming out of this. Maybe you are all at the same sickle cell center, and maybe there's a multiracial makeup of the staff, and you've never had these difficult conversations before. I would encourage you to do so. This is part of the solution, I think, to making sickle cell care better. You didn't know you were in for this today. But this is where we're headed. At our place, we're trying to have these conversations, and I would encourage you to do that in order to give more culturally sensitive, less biased care. And Dr. Royster, do you have any parting words for the audience now that you've heard the whole thing about sickle cell?
Yeah, well, no, this is, first of all, I'm appreciative to be a part of this event. It's great, and to see that there's so many people from all over the country that are tuned in. As you and I were just talking, one of the things that came to mind around the work that we do is when we talk about this self journey that we all have around becoming more open and anti-racist, anti-oppressive, is that there's two quotes oftentimes that we've used. One is, I believe it's Socrates saying the unexamined life is not worth living. And that if we don't examine, what motivates us oftentimes unconsciously, then we're not able to really fulfill our true potential. And then the other quote, which I like, is the examined life is painful. And that is from Malcolm X.
Wow.
And so as we start to recognize and do that internal work and realize our biases, our prejudgments, it can be painful to us because we know that we're not supposed to have those things, or we don't want those. But in reality, once we become aware of them,
Yeah.
then we have the opportunity to grow and grow beyond them. So we encourage people to really do that journey.
And I can validate the painful part. I told you how pissed off the faculty were. Even the medical students didn't like being graded down on those IDI inventories when they were given them. And we called it narcissistic injury. They're used to getting A's. And used to always being told they're on the top and they're the best. And finally there's something that they're not the best at. But uncomfortable is okay. Right?
Exactly.
As long as we're trying to make progress.
Exactly.
Okay, I hope you've enjoyed all this. Shirley's going to come on and close us out. Thank you, guys.
Thank you.
So I hope you all have enjoyed our day today. We've had some wonderful talks, some wonderful guest speakers. We're very grateful to Dr. Royster, to Dr. Wolf, and our colleagues over at VCU who took the time out of their busy schedules to come and see us today. I would like to just give you a couple final housekeeping tips. Go over the claiming credits again one more time and to let you know what we're going to be doing tomorrow. First of all, as much as we truly love seeing all your names on the screen, if you have not noticed, and I think I pointed it out earlier, we've been trying to close all of our talks out with a picture of our pets. Now, we don't want to be discriminatory because we realize some people do not have pets. So we are going to ask you tomorrow to maybe bring a pet picture of your favorite animal, or a plant picture. We have had some people who have told us their plants are just as important to them as their pets. And when we open up our dialogue tomorrow, we'd love for all of you, if you feel comfortable, to turn your camera on and show us your pet live, or bring a picture of your pet and maybe put that up there as part of your profile, or your plant, or whatever you feel is something really important to you. We kind of thought that was fun. We did it last year at the end of the conference, and we thought about it this year, maybe doing it a little bit more earlier so that throughout the course of the week, while we're up here presenting, we have some beautiful pictures to look at of things of all of you that are attending. We also would like to make sure that you are aware there's a post-test link that is going to be sent out to all of you at the end of today's segment regarding the information that was discussed today. In order for you to probably move forward to getting your CME credits, we do need you to fill that out, and we are going to go over that tomorrow. So kind of recapping what Dr. Smith and Dr. Royster said, we're going to take about 30 minutes tomorrow to go over the post-test questions, but also maybe process a little bit of the dialogue of what transpired here this afternoon. It was very enlightening to me, and I've actually heard similar talks from Dr. Smith in the past, but also kind of maybe try to figure out some ways for us to move forward as a society. It all starts with one person, and maybe we could have that dialogue tomorrow a little bit if somebody feels comfortable. If you don't, that's fine as well. So again, I'm going to just ask that you go to the CME website, vcucloud-cme.com, sign in using your email address that you used to register for the event, and click My CE and select Evaluations and Certificates to complete today's portion of what you attended if you want to collect CME credits at the end of the conference. We are going to wrap up a little bit early today. Tomorrow we start again at 8:15. So we hope to see your bright and shining faces. And again, we want to thank all of our presenters who joined us today. And more importantly, we want to join all of you, or want to thank all of you for joining us. We have people from all over the country. We feel very privileged to be able to offer you this conference. We hope that you will continue to see it as a groundbreaking movement towards the work you're doing with the sickle cell population, as well as overall care for patients with health disparities. So thank you again very much. We'll see you tomorrow at 8:15. And don't forget to bring your pet, plant, or whatever important picture of yours that you have. And if you can, turn your camera on in the morning so we can see your beautiful faces. Thank you all, everybody. Have a good night.